medicine and a past president of the World Federation of Intensive Care Societies. And you can say before that I'm professor of intensive care medicine at the University of Brussels.
Okay, still okay, many years. So just on the topic of the difficult clinical trials, it would be good to have some conclusion around that as well, though. Not just to say it's difficult to get information on, but where does that lead us? What are the challenges today, or what are we moving forward? So it's good.
I can do that. 3 minutes?
Yeah, 3 to 5 minutes is good. And longer if you like.
Okay.
We're good to go. So I'm here with Professor Jean Louis Vincent. It's an honour to have you here. We are at the ESICM now. You can look to me. It's fine. He's capturing everything. So we are at the 32nd ESICM meeting here in Berlin. Jean Louis has been past president and also past president of the World Federation of Intensive Care, and is currently still practicing professor in University of Brussels ICU. So we were discussing earlier about the difficulty with the outcomes of clinical nutrition in the ICU. Can you expand on that as to why it's so difficult to come to some conclusions?
Well, it's not only on studies on nutrition. It is in general. Today everybody speaks about the negativity of our trials. We are in some kind of depressive phase where all trials do not show any difference in outcomes. And this is true for nutrition as well as for other things. And we had a roundtable conference on this, on nutritional issues in Brussels last year. And the outcome just came out in critical care a few days ago. And we reviewed this literature and we realized, and I'll speak about it this afternoon actually, we realized that every single study was on critical ill patients, targeting mortality. But how do you want to change mortality in a mixed population of ICU patients? It does not make sense. It's not achievable. And so there are two things we should do. And again, that's what I will discuss this afternoon. One is we should no longer focus only on mortality, and especially with nutrition. How do you think it will influence mortality? When you nourish people properly, you expect them to become stronger, recover a good muscle force, and be more quickly rehabilitated. That's what we should look at. And secondly, we should stop putting all the patients in the same group, in the same bag. Patients early after trauma are very different from patients who have been septic for 10 days, and very different from patients with heart failure who may stay in the hospital for several weeks because they are in a bad condition. So why do we put all these patients in the same trial? We should stop doing that, and then we will start to see some important things emerging. Nutrition is so important. Don't tell me you can eat whatever you like, the outcome will be the same. That's not true. It cannot be true. But we need to personalize the nutritional support, including with vitamins, with oligo-elements, etc. We need to measure what we do.
So why now? Do you think it's because there have been so many trials that have been homogeneously grouped that we realise now it hasn't worked? Or why after all these years does it come up that we shouldn't be looking at it this way?
Oh, I have said it for years. And people smile and say, well, that's the way it is. And the paper is published in the New England Journal because there are 3,000 patients enrolled. But it's a negative study. So at the end, you can criticize everything. Now the big thing is undernutrition. Permissive undernutrition. What's going on? At the end we will stop nourishing our patients? No way! It's very important.
Very important. So on a practical note, what do you do in your intensive care? How do you assess your patients?
Oh, we published it in the Lancet not so long ago. We start enteral nutrition as soon as possible, when it's possible. So that means since admission. And we started usually, we increased the number of calories progressively, although in some patients, like those after head injury, you may start quite quickly and increase it quite quickly. So that's how I don't believe so much in protocolized care. I think we need to individualize these decisions. And so we try to achieve 25 calories per kilogram as a general rule. And we try to give 1.3 grams of protein per kilogram per day as a general rule. That's the standard recommendation. We do not use indirect calorimetry to assess the exact number of calories that the patient may need. It's probably something we should do. I believe in measurements, as I say. We need to individualize these therapies. But right now, we do not have the instruments available. But in complex cases, that would be something to do. Yeah.
So actually, you're not too far away from the guidelines. What you do in the University of
The
Brussels.
guidelines are not very precise. Like all guidelines are, they don't say very much. So, but of course, the guidelines are good. I have nothing against guidelines. And I participated in many guidelines in other fields.
So the next steps, what do you think is needed now to come up with some concrete help for those that are not as well informed as you?
Well, we need to start with a good question, with a good rationale. Not just enteral versus parenteral from the beginning. That doesn't make sense. If you can use your gut, use your gut. So, that kind of question is stupid. So let's go for a good question and let's address the question in a relatively homogeneous group of patients, like, in the early stage or in the later stages of their disease process. And then let's look at organ function and strength and physical fitness. And of course we can look at mortality, but mortality should not be the primary endpoint. That's ridiculous to look at mortality for all studies. So we need to have better endpoints as well. Better patient population and better endpoints for a good question. That's all.
There's some work to
and
do.
We will succeed.
Yes.
Yeah.
Thank you very much. It was a pleasure.
Thank you.
Thank you. No, very interesting. Thank you.